So as we go ahead and begin, if you would please make sure, if you're on Zoom, just make sure your microphone is muted. And then of course, those who are in the audience, just remember to be engaged in the session. For those who are on Zoom, I'll put a link to the evaluation form in the chat box towards the end of the session. And then also for those that are here in person, I'll be handing out an evaluation if you can help us with some feedback. For those who are claiming CME credit, this is the activity code for today's session. If you have not yet registered, I'll go over some information in just a minute about that, but please make sure that you send this code in before midnight tonight in order to receive your credit. So if you have not yet registered, you'll need to send your email address to the, you'll text that email address to the number listed here. And then from there, at that point, you can text attend and the code for today listed there. And you should get a message that says that it was successful. Also, for those who are claiming credit, make sure that you do check your CME transcript. If you're having any issues, just be sure to check in with me if you need to, or the CME office. Also, we just want to mention that we offer AAFP credit for those who are members of the AAFP, and their information is listed there. And it is also, we want to make sure that we are addressing these nationally established physician core competencies that you see here listed on the screen. So those are there for you to see. And we have a very special week. This is Primary Care Week. We have a special guest speaker, and I'll let Dr. Cancino introduce her in just a minute. But our theme this week has been caring for the caregiver. So I will let Dr. Cancino go ahead and introduce and give some information about the presentation here.
Thank you very much, and very honored to be able to do today's introduction. So just a little bit about today and what's bringing in our speaker. So the Wirt E. Ballou and William Richard Hawley Senior Distinguished Endowed Lecturies was established in 2012 through a generous gift from James E. Hawley, MD, and Mrs. Carolyn Hawley to honor through educational collaborations. Annual distributions from this endowment are used to promote and disseminate best evidence of the benefits of advanced primary care models, inspire medical, nursing, and physician assistant students to dedicate their careers to provide advanced primary care, and engage and network students, family medicine, medicine, and pediatric residents, and advanced practice nurses and practitioners and researchers in developing innovations in advanced primary care. Today, it's really my honor to introduce this year's Ballou Hawley Distinguished Visiting Professor, Dr. Suzanne Mitchell. Dr. Mitchell is Associate Professor and Director of Research in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School. Dr. Mitchell's health services research focuses on patient and caregiver experiences during care transitions. Dr. Mitchell is a lead investigator for Project RED, the re-engineered discharge, with a focus on adaptation and dissemination of the Project RED in diverse settings and populations. Dr. Mitchell also studies digital health innovation serving older adults and patient populations. Her cutting-edge research study, Women in Control 2.0, was among the first clinical trials of immersive technology enabling group visits for diabetes. She's a board-certified family physician and a palliative and hospice care provider. She completed medical school at Wake Forest University and master's in clinical research at UCLA. She completed residency training at Linda Memorial Medical Center in Los Angeles and her academic fellowship at Boston University School of Medicine. Now, I have known Suzanne since I was an academic fellow at Boston University a little over 10 years ago, and I've had the pleasure to know her both personally and professionally ever since. She was well known amongst us fellows at the time for her knowledge on quantitative, qualitative research methods, but more importantly, though she applied these skills, she did so in a patient-centered way in research centered transitions of care, integrative medicine, diabetes self-education, shared decision-making, and patients with depressive symptoms, patient caregivers, and virtual reality. Areas that impact doctors, patients, families, and entire health systems. Thank you, Suzanne, for your guidance early on in my career. And thank you for taking time to be today. Hi, and Dr. Suzanne Mitchell.
It's okay not to have a last one while I'm speaking. All right, and I can advance like this, and I should stay right here.
As much as you can.
Okay. I think I need to stand on my toes. All right, good afternoon. I'm so delighted to be here with my colleagues, in family medicine, and to be invited to San Antonio. And thank you, Ramon, for that, the honor of being here to share my work. And I think you, I hope that you will share my passion and feel compelled also to raise the profile of family caregivers where I share this work with you. And to begin with, I would love to start by just having dialogue. I'm a family doctor, and I'm a palliative and hospice doctor, so I love interaction. And I'd love to start by asking you to think of a story from your own practice or your personal life that you have either participated in or observed about a positive family caregiver experience, and try to think about what are the elements of a positive family caregiver experience. What role have family caregivers played in the care team and in delivering high quality care to our patients? And how do you describe that in a personal story? So I'm sure that we all here have anecdotes from our practice or your personal life, or maybe even having been the recipient of care that you could share that kind of helps to illuminate is that we're talking about today. So I wonder if somebody would be willing to share something from your life or your practice where a family caregiver was really an important part of your care plan, your practice, or the patient care experience. I know it's lunchtime. I've caught you with your.
I'll give an example. For instance, just this morning, it's like a appropriate clinic, gentleman in his early 20s, but has pretty severe autism spectrum disorder to the point where he really can't verbalize much. He's here with his parents who are actually elderly that had him late in their lives, but they've been with him from at every visit here for his first psychotropic appointment with them. And not just in their ability to verbalize, what the patient is feeling, but just all they do for the patient, in every aspect of life, without them being involved in the care. I can't imagine how much worse off this individual's health and also life would be in general.
Yeah, I think I'm glad you brought up a case of a parent and child, because a lot of times, and in my presentation, I do focus mostly on older adults, but another really effective and powerful advocacy are parents of children with complex illnesses and grandparents who are serving as primary caregivers. And they, along with the AARP, have been very strong advocates for the caregiver resources and support services. So I'm glad you brought up that example of parents of children with complex care issues, and how much their participation is critical to the care recipient's well-being. Yeah, wonderful. Anybody else have an experience or an example, even from your personal life, about caregiving? Yeah.
Story of friends in the Air Force who subsequently they actually both passed away. But when the wife was passing away, we had a plan. We were all going to go out to dinner one night, and we came in from out of town. And by the time we she wasn't really able to go, but one of her friends, several months actually, having been here and kind of turned experience more into preparation. So she and her daughter, who has a disability, spent the time when we were at the restaurant, prepared a lot, right? So it was kind of a very personal note to something that the plan fell apart, but it has to be at the end. I think finance, which would be
Yeah, so I think one of the things that always kind of gets highlighted for me in these stories about caregiving is helping the care recipient feel and stay connected to their world of people who are well, their families, their friends, their social life. Really, without the support of the family caregiver, that connection to the world that brings them meaning to their life would be really difficult to maintain. And there's an interesting book called Infatuated by My Illness. It's a really good, very short read by a New York Times film critic who developed terminal prostate cancer. And he talks about what he thinks the role of his physician is. And his idea was that the physician's role is to help the person with the serious illness stay connected to the world of the well. And I actually feel like family caregivers really play that role in most cases. That one time I was doing interviews with men with type 2 diabetes, and this one gentleman told me that it was unmanly for men to read food labels in the grocery store. And but he also told me that he felt like he didn't belong at his mother's table anymore because of the restrictions on his meals and the carbohydrates. And he just said that diabetes just makes him feel like he doesn't belong in his work with it, to try to manage that care plan. It was a very powerful example of feeling alone and isolated by your illness. And I think that family caregivers can really help bridge that. And actually a medical student yesterday gave me a good example. She said she took care of her grandmother for 2 months during the pandemic, and she cooked meals that were from their cultural diet and cultural menu, but she adapted it for her diabetes and heart failure so that she could still participate in those meals together without feeling like she was missing out. I thought that was an example of how family members can serve. So there's a beautiful article by Rachel Remen. I did share it with some people about the concept of to fix, to help, or to serve. And how when we help people, in some ways we can inadvertently undermine their dignity and independence and see them as weaker. But when we serve people, we serve them as equals, and that helps to bring up their feeling of dignity, even in the face of declining health and increased dependence on others. So I like to bring this out. Does anyone have something they want to share about family caregiving or what they think is a good family experience? If not, I'll let you off the hook. Okay, I'll go then. So that just to bring that up to contextualize, I'm about to present to you the documentation of the plight of the family caregiver, because up until years ago, we knew that family caregivers kind of had it rough, but we really didn't know how rough. Nothing was really documented about what kind of struggles they were experiencing, and also the very slow transition of their scope of work, the scope of what a family caregiver is expected to do. And so about 10 years ago, a group from AARP and the United Hospital Fund, our friend Carol Levine was one of the co-authors, conducted a study called Home Alone, and really effectively documented the very serious situation with family caregivers. So without further ado, I'll share a little bit of that experience, and please, raise your hand, ask questions to let you know. I think my slides are my slides. I love technology, but it keeps coming back to the first slide. How's that? Here we go. Okay. All right. So just so you know, I do have equity in a company called See Yourself Health, which was founded based on some research that I did in immersive technology. And so I've been in the past for lectures on relationship care industry. Goals for the talk are to increase your awareness of the critical gaps of family caregiver availability and their supports, about disparities among family caregiver resources, and the emerging policy changes to try to help solve some of those problems. So this was an interesting diagram that the School of Medicine asked me to include. I thought it was really cool because it's where do family caregivers fit in the healthcare system? And really, if you think about it, it crosses over all of these concentric circles. We have policies, we have the patient, the care recipient at the center here. And then in the outer circle, we have the family caregiver. And I would say that I could probably make along with the patient, and I'll talk more about that as we go through the conversation. And then within that is the hospital and the targeted interventions that we see trying to engage the family caregiver in hospital and clinical setting processes of care. And then the policies that are coming down to try to help make family caregiving sustainable. Escalating, the whole point of this is we are sitting on the tip of an iceberg, a very important risk to our healthcare system, really. And that is the 53 million caregivers across the nation who are delivering 34 billion hours of uncompensated care to their loved ones. And they're not always family members, by the way. I just want to qualify that many times a caregiver is a friend or a non-relative provider. So 34 billion hours of uncompensated care, estimated to be equivalent to $470 billion a year. That amount is, there's no way that the healthcare system could ever supplement that. We could never provide that care with resources that we have available to us. So we're looking at a very high risk workforce that is uncompensated and struggling and really facing burnout, but yet the demands for more and more family health caregivers is just increasing. So the demand is largely driven by the aging population, about steep increase in Alzheimer's dementia, right? So there's just, that's another iceberg. There's rates of diagnoses of Alzheimer's is skyrocketing, and that's putting on, and also the trajectory of caregiving for Alzheimer's is such that people will be caregiving for a very long time. And also the average size of families is much smaller. So instead of having 6, 7 kids to adult children to help provide care for 2 aging parents, you have 2 or 1 or none available to help support aging parents. Unpaid caregivers are those, generally they're adults provide care that's uncompensated. We'll talk about the programs that are available for family caregivers to get compensation. But in general, they're performing not just personal care duties, but increasingly more than half are providing skilled and what used to be considered nursing. And that is creating a tremendous amount of distress among family caregivers. Not only that, the inordinate amount of time being spent in care coordination is making it very difficult for people to maintain their jobs and manage as caregivers. So I mentioned this home alone study. The home alone study was conducted with over 1,500 family caregivers. Really the primary goal to document the family caregiver plight and experience. And then they revisit to see if things were still unchanged, which they've unfortunately found many of the issues facing family caregivers didn't change. And from that, the Home Alone Alliance was established to try to help solve some of the imminent issues facing family caregivers, particularly around education. So Home Alone found, in a interviewed 177 family caregivers, the first time around, the majority of the informants were non-Hispanic white, many of them were female. 46% said they were delivering medical or nursing tasks, and many felt that they had no choice, that when they were named as the designated family caregiver, there was really no choice in the matter, and that their decision to become family caregivers was helping their loved one avoid institutionalization. A third of them were doing complex wound care that they felt overwhelmed by. 78% of those doing medical and nursing tasks were doing really complex medication management, IV fluids and injections at home, and some doing dialysis, which somebody brought up this morning. Overall, 66% reported fear of making a mistake. Now, you can imagine, I bet all of us in this room and on this call have had a moment in our career where we were afraid that we would do something that would hurt somebody in our practice. Can you only imagine how that must feel when it's somebody you love, that you might make a mistake with the medication, or the injection might go wrong, or the wound care might not go as it should, or you didn't do the right dressing as frequently as you needed to. This happens so easily. In my hospice practice, what we expect of family caregivers to manage morphine and drugs like for pain management, and it's just no wonder that they managed to get through the hospice experience, because it's a lot of responsibility in a high-risk situation under a lot of emotional duress, and yet we have no alternative. So we have to try to do a little bit better. So they revisited Home Alone in 2018, 2019. This time they interviewed over 2,000, and they got a little more racial and ethnic diversity, as well as socioeconomic diversity. And unfortunately, they found pretty much the same kind of outcomes. So they found most still felt they had no choice and were on their own. 70% reported an emotional burden of pain. And diverse family caregivers reported more experiences with strain and worry about making a mistake. And I think that points to part of it being lack of access to services, maybe in different languages, to health literacy, and to resources, the availability of resources to support them. Many family caregivers feel socially isolated. And despite the implementation of the CARE Act, about only 20% of family caregivers at least 24-hour notice that the patient would be discharged. So this is a major event, being discharged from a hospital, and you get less than 24 hours to prepare for it. And you're the one that has to implement it. And that's really unfair, I think. So, slides, okay, yeah, okay. So unpaid family caregivers, the need is escalating, and the availability of family caregivers is diminishing. We're going to have a really hard time meeting the demand. Many family caregivers have difficulty coordinating care, and have had an impact on their own health that they attribute to their responsibilities as family caregivers. And many are facing the burden of Alzheimer's disease. Very difficult to manage behaviorally. And because of that, there's an increase in emotional distress, and the longevity of Alzheimer's caregiving is also a difficult part of that caregiver experience. Most family caregivers are in that role because of aging loved ones, mobility issues, and Alzheimer's dementia. Those are the top runners, and part of the reason why this talk is largely focused on that population. But there's many people serving folks with all different and younger populations. So family caregivers are mostly women still, but you can see that's changing from about 75 to 8% being women, now 40% approximately men and 60% approximately women. So we're seeing more men serving as family caregivers. Mostly boomers now, but younger people are getting involved in caregiving now because why? Because families are small, we're smaller. And so we need to engage younger family members to help shoulder all the responsibilities. 45% reported a negative financial impact. That's either on their ability to work or out-of-pocket expenses for long-term services and supports. So there's been a tremendous impact on family caregivers that hasn't been accounted for by the healthcare system. So another interesting aspect of the family caregiver situation is the changing demographics. As I mentioned, there's increasingly more men are involved in family caregiving. And we see that as our national demographics are changing and the disparities or differences in rates of Alzheimer's disease, especially, we're seeing increasing high burden family caregiving on, they're more likely to be in a high intensity situation, I think partly because of socioeconomic issues and the availability of long-term services and supports. So when they don't have people to come in and help them, they have to do it themselves. And that means they spend more hours doing caregiving than people who can pay out of pocket for long-term services and supports. And people don't realize this dilemma until they're in it. They don't realize that there's not going to be somebody or a program or your insurance to cover the cost of somebody to come in and do personal care, to deliver meals, to clean your house, all the things that allow people to age in place. And this includes the ability to die at home. And, that is a really important distinction because we think that everybody wants to die at home, but not everybody wants to die at home. And even those who do don't all have the opportunity to die at home because they don't have a caregiver to serve. That's the requirement for hospice. So these are some of the things that people don't know until you're in the big wilderness of not knowing. And that's one of my family caregiver quotes I'll never forget. As I mentioned, African-American, Latinx families are more likely to be in high burden situations. That's over 20 hours a week in family caregiving. They're also more likely to also be working full time. And despite that, most of them are providing medical or nursing tasks. And if you ask them how they learned how to do it, like medication that prove that support that. And this survey really points out that people are learning on their own, and that's just very, very risky. They don't know, and when they ask for help, they don't get it, and so they feel like they just have to figure it out, and that's a very big. The use of paid help, again, only 30% had paid help in the home. And that's despite the complexity of the responsibilities that they have. I think that points to financial constraints as well as the availability of people to do this work. We don't have enough people to do that kind of work, even when they're paid. And when they are paid, they make less than they can make in a real or a fast restaurant. And so we have to do at providing to do that work. So when you ask people who are serving as unpaid caregivers, they'll tell you that they need support, they need training, and they need help coping. And even more worrisome is that they feel undervalued and unseen by the healthcare system. And that's something that we can do something about today, simply by saying, when you see a family caregiver, as you saw in clinic, is to thank them for what they do. It's not much, but it really matters that they feel recognized. It helps. And one of the things that's really been troubling for them is the lack of visibility and lack of engagement. It's not enough, but it will actually do something now that will be meaningful to them. 38% report feeling despair, 40 up to 70% have reported depression, and 40% feel burned out. And that is very worrisome, because if 40% of family caregivers gave up caregiving, we couldn't replace them. And we couldn't even institutionalize their care recipients. And so we would be in a real crisis, for not to mention the lost income, $520 billion a year of lost wages and out-of-pocket expenses. This is pretty devastating, right? We're asking people in some cases to live in poverty as a result of being a family caregiver. Not only does family caregiving have a burden on the caregiver, but it also contributes to poor outcomes and unplanned hospitalization use, which means increased cost of care. So there's a value proposition in here somewhere for value-based care to see that poor family caregivers actually does bend the cost curve. One of the problems for family caregiving is trying to figure out where does it fit in the traditional mechanisms for payment. Because, you know, if you were a health plan, you say, well, why should I have to pay for a caregiver's mental health services, right? The problem, my responsibility is the care recipient, right? And so this dilemma of who takes care, obstacle for caregivers to get help for themselves, and we can hopefully find a solution to that through policy like the RAISE Act. So I want to just focus a little bit on something I know very well, which is care transitions, readmissions, because these are really important events. So some might be going along okay, and then something happens at hospital. It's a destabilizing event for the family caregiver unit and for the needs of the patient. So lots of times if somebody has an exacerbation, they come home a little bit less than they were before. And that means they have increased needs. And sometimes those needs are new to the caregiver or more complex. So an hospitalization event is actually kind of the last thing a caregiver actually wants to see. And not only that, but when they're in the hospital, it's just a frenzy of trying to figure out what's going on. There's poor communication, new task problems, and appointment coordination that just adds to what's already a complicated situation. So to try to understand what helps people or what was important to people and their caregivers during a care transition, we were funded to implement Project Achieve. Project Achieve was spearheaded 6 leading investigators in care transitions, and I was one of the supporting investigators. And my role was to do the very first step, which was to do a bunch of collect a bunch of empiric evidence to find out what mattered, because we actually realized that we didn't know. Nobody had ever asked patients and caregivers what was most important to them as an outcome of a hospital or a care transition. And so we interviewed 238 care recipients and caregivers across the country in 6 different geographic regions to find out what mattered most. And I put this diagram up there because it was our consensual model. And frankly, I can't even explain it to you now because it's so complicated. Like if you want to talk about hospital discharge and care transitions are just 100 moving parts. And it's really difficult to smooth them out because of people have so many needs. And I think that's part of the reason why finding a solution and reducing readmissions has been such a challenge. The people that we interviewed were largely around 60 years old, mostly women were in the caregiver realm, group. We had a fairly good mix of people representing different race and ethnic groups, and about 43% of care recipients were considered low health literacy, but only 23% of the caregivers were evaluated as low health literacy. So this was the group that we interviewed, and here's what they told us mattered to them. And you're probably sitting there going, of course. Of course, they want to feel cared for and cared about. Of course, they want to have continuity and accountability of care and effective communication, and they want their needs anticipated and they want to feel prepared when they go home. Of course. And that's what the funders said to me, like, are you kidding me? And I was like, well, here's the rub. Despite spending millions, if not billions of dollars to help improve care processes from the hospital and clinical side of things, from the patient and caregiver perspective, things still feel like a roller coaster ride. They feel unseen, they don't feel cared for and cared about, they don't feel like they're communicated with effectively, and their needs are not anticipated. And so as a result, there's a tremendous amount of fear, mistrust, and distress. So we've done a lot of things to help improve care transitions from the perspective of the healthcare system, but we haven't done nearly enough to help from the other perspective, which is from the perspective of the care recipient and the caregiver. And that's what I think was the most important finding for Project Achieve. And this is just our conceptual model, which says it's not necessarily what you do, it's how you do it. It's when you communicate with compassion and empathy, when you provide actionable information, anticipate needs, have uninterrupted care, right? That's our thing, right? In primary care, we want continuity. And people want to have somebody they know show up that they think is going to help them and be accountable for their outcomes. So when things don't go right, mistrust, anxiety, and confusion result. So we did a secondary analysis of the Project Achieve data that we collected, looking at caregiver needs specifically. And what we learned was that caregiver needs are not the same as care recipients. And that's another thing that we tend to do in our healthcare system process, is we tend to lump the caregiver, care recipient needs and outcomes with all together. But actually, these are two different stakeholders that need very different things: burdensomeness and loss of independence. And these probably are not surprising to you, but again, documentation of the experience is really important. So bewilderment, like the caregiver was like completely unsure about what was happening, what was going on, what was going to be expected of them, and they felt responsible for the impact of that poor preparation. So we had to pull all our tidbits of information together. It was like canvassing on the floors of the hospital, just trying to assemble information, trying to figure out who's who, what's what, and what matters. I mean, it's complete chaos to them. At discharge, as a caregiver, I had to find it all out by myself. And when you have that job and your own responsibilities, you miss things. Had I known, her health would have been a lot better. And it's because of my ignorance on my part and the mistakes. This person feels responsible for not knowing what to do and the decline in her loved one's care. And that's just unfair. It's not fair that people are expected to learn as they go along. Conflict on readiness to transition home, right? You've probably seen this, right? The patient's like, I'm ready to go home. I feel great. I'm going to do okay. My daughter's going to take care of me when I get there. And then the caregiver's like, no, you're not ready. You still need more attention. This isn't, we're not ready to go home. And then suddenly there's conflict in that critical relationship that we need to stay healthy. And we start to see that undermining of the caregiver partnership with the care recipient. So disagreement, right? So now you have the kids. This morning, somebody told me how wonderful this caregiver was at helping her husband. If you think about it, that caregiver's role as the enforcer puts them in the, bad guys, right? Where the person who's taking the medicine is like, I don't have to take it. The nurse told me I only have to take it if I don't feel good. And the care recipients, the caregiver saying, that's not what I heard. I heard you have to do this. And now you have a battle of will. And this person said, I'm losing confidence. He's winning the battle. And I can't fight this fight anymore. And then accepting help from others. This is another really common area of conflict where the patient is reluctant to accept care from a stranger and the caregiver is desperate for help, right? And so, you know, when they released her, I knew it was coming. I was happy because I also knew that another person was going to be helping. And a lot is required when someone leaves the hospital and you need to go to work. And even more, you're not feeling healthy yourself. So here's a caregiver saying, you know, there's a lot of work coming and happy somebody's coming in. But on the other side is a caregiver saying, you know, I feel my mother's lost dignity. And, you know, that makes me feel sad and guilty. And so there's another tension between the needs of the caregiver and the needs of the care recipient. And then finally, this concept of burdensomeness and loss of independence. And this is an area I think if anybody's looking for a research project, I think deserves a lot more research. We have a lot of research on burdensomeness and how it influences people's willingness to care. So a caregiver thinks that telling their daughter that they have chest pain is going to make their daughter miss work again and have to take them to the hospital, they might just suffer in silence because they don't want to put any more burden on their caregiver, right? And then they end up at the hospital and the hospital saying, why didn't you tell us you were having chest pain? And how can they explain that they felt the sense of burden, right? And so I knew I was a burden. I had a mild stroke and my family didn't want me to live alone anymore. And I felt kind of mad about it, right? So now you're like kind of mad about it and it creates more conflict in the relationship. And then from the caregiver perspective, you know, they recognize, you know, my parent doesn't want me to see them as vulnerable and you want to just scoop them up so that they don't get in trouble or fall or have a bad outcome. But then you don't want to take everything away from them, right? You don't want to take all that they have for themselves, all that they have left for themselves by taking them out of their homes. The final, I think, is the most really was for me the most worrisome was the quotes that really correlated with caregiver burnout. I don't know how people can do it for years. This is killing me. It really is. Physically, mentally, it's just so draining. These are my retirement years. I wish none of this had happened so I could be free. I feel a little bit that it's a burden. There's no relief. So if you're it's a 24/7 job. You lose your patience and there's a lot of anxiety. So you can hear the desperation in their voices. Just more about emotional distress. So I feel like, you know, this is a pretty compelling story about the plight of the family caregiver. And yet the caregivers, if you ask them, they wouldn't have it any other way, right? They are not going to leave their loved ones, abandon them to what might be a much more devastating outcome for them. But at the same time, they really can't keep going on this way. So what's in the future? What do we have to offer? So there are some policy changes coming down. There is some digital health innovation being funded. And more importantly, the pressing need for investment in a caregiver workforce. So just really quickly, the CARE Act was promoted by the AARP, which is an incredibly effective advocacy group. This was designed to help recognize caregivers and get caregiver training at the time of hospitalization. The policy focuses on hospitals needing to name a family caregiver, contact that caregiver with 24-hour notice about discharge and teach them what they need to do. 42 states have adopted the CARE Act, although enforcing the CARE Act is a whole nother enchilada, right? Like we don't really know exactly how to make sure that it's being implemented, and that's a challenge. The Home Alone Alliance was formed because of the Home Alone study, and they've been putting out educational resources for family caregivers for just a Band-Aid on a big problem. Project Red and Dr. Cancino's contribution to Project Red was to create a caregiver toolkit that helps people in the hospital assess caregiver needs at the time of discharge. So that's another example of how the CARE Act is being implemented. And then the RAISE Act, which is the most current activity. This was passed in 2018 with the help of the AARP and also the Grandparents Coalition. And in 2021, they wrote a report kind of characterizing the unmet needs for services and support. And in 2022, just last month, they released their strategy, which includes 350 actions that they intend to take and over across 15 agencies. And I'm just going to show you quickly that that's designed to increase awareness and outreach, build partnerships and engagement, to provide workplace security and increase research and enhance long-term services and support. But nowhere in here does it say you don't have to be a caregiver anymore. So there's no intention of saying caregivers will get off the hook or not have to do this kind of service, but it's designed to try to make it sustainable. So I think it's relief, but it's not respite. Oh, there a little bit of respite. We know that long-term services and supports help with family caregivers, although eligibility for long-term services and support varies greatly across states. So lots of people find themselves having to provide this out of pocket if they can afford it. And then lastly, I'll just touch on technology. So caregivers are very tech savvy and they report that, yet only 7% are using technology to help them get their jobs done. And I think part of that is because a lot of the technology is still really early. It's not really ready for prime time, and it doesn't help them solve their primary problems, which are to save time, manage the logistics, make care recipients safer, increase their effectiveness as caregivers, and reduce stress. So if the technology doesn't fit one of those bills, they really don't have time to worry about the technology, adopting the technology. Evidence of health tech that's worked on medication management devices. So we do see those in the home where sensors and other things, robots that talk are getting increased uptake. So Alexa type of things that will help with dementia behavior management, caregiver peer support. I would say for dementia caregivers, this is a critical development for peer-to-peer support. Wearables that help track people down when they're wandering or identify people at fall risk, and then home smart sensors. So in summary, I just would like to say thank you for being aware of the plight of family caregivers, and to please approach them with compassion and even trauma-informed care, because many of them have what I would think would qualify as trauma and a little bit of PTSD, and they deserve to be approached with care. They are a vital and unseen workforce. They're struggling and the burden is growing. And many of us are going to find ourselves in this situation ourselves soon. We need to be sensitive about the changing demographics and the need for services and supports in different languages. And to be aware of the changes that are being promoted by the policies that are coming through, especially those for the RAISE Act. And, you know, if you ever get touched by a budding entrepreneur who wants you to try out their technology, well, maybe give them a few minutes of your time so that it comes out right, instead of like something that you or your patient would never touch. So thank you so much for your time today. I would love to hear your questions or comments. And it's been great to meet you. Any questions or comments?
Question about the transition to care. What would you propose will be a solution or idea for that transition to happen for the caregivers to be prepared?
Yeah, you know, I think that the biggest thing is involving the caregiver in the discharge plan. But, you know, I was talking earlier today about this is kind of like when you're doing a home renovation. You could just add it on like a sun porch, or you could actually redesign the kitchen. Right. And I think today we're just adding it on like a sun porch, right? We're just lopping it on to what we already do, and we're not really changing the way we do care. Whereas if we really want to do it right, we really need to redesign our processes in the hospital so that caregivers can be part of the discharge planning process. It's an aspiration. We don't have it yet. At the very least, I think we can do a family caregiver assessment at the beginning of the hospitalization to find out what the unmet needs are, so that that can be taken into consideration while we're making discharge plans. Because we often don't find out, we don't even ask. We just give them the plan and expect them to implement it. And they get home and they don't even realize that they don't know how to implement it. So there's a lot of, I don't know what I don't know until I'm in the big wilderness of not knowing. And we don't know how to anticipate those needs. The best care manager I ever met was somebody who used to be a home health nurse. She had been in many homes and she could anticipate what was going to be needed at home to succeed. So she was a very effective care manager at the point of discharge. We need more people with that perspective so that they can ask the right questions and do better assessments. Yeah, that's what I think we can do now. Yeah. Yeah.
So I know you touched on it, but just to emphasize the point, I think a lot of the caregivers are feeling really lonely. So
Yes.
they're dealing with a sick person all day, so sometimes the person's not really engaged, or sometimes they are engaged, and sick people aren't always at their best. So they're having some conflict with this person they love, and it's just very, satisfying.
Yeah, and they're hard to engage. So that's why I think the peer-to-peer interventions are really effective, because somebody who knows what it feels like to be them is the best way to capture their attention. Someone like a dementia caregiver program, they have a coaching program that's being disseminated through the VA, peer-to-peer dementia coaching. And I think I really love peer-to-peer interventions, because I think getting advice from somebody who has been in your shoes and succeeded is powerful. And especially for people who are difficult to reach and engage, like caregivers. So I think that's an example of an effective potential solution that could engage family caregivers and give them the support network that they need. Somebody to actually empathize with their situation, but also teach them more effective. I agree. I think it's not an easy audience to capture. Yeah. Yeah.
Like we should have played about the caregiver, like depression, and I'm imagining like in caregivers are like trying to meet all these appointments, like for them in big care. And I was wondering, like for us, like we have that, just like when we see the caregivers might offer, oh, what was like last checkup for you, like engage the next appointment people might go to both, because they're running around to try to do all the appointments, but not, I guess, getting care for themselves.
Like getting two kids seen at the same time, right? We do it for kids, but we don't think about doing it for adults. Yeah. And that's good if your caregiver is also your patient, right? But many times the caregiver is probably being seen by, or may not have any insurance, or may not actually have. So that's a good example of why the family medicine framework works, because, we see the whole system as being part of our responsibility and realm of care. So a family medicine model works in that situation. Yeah. And also a lot of caregivers are not married or children. And that's becoming increasingly true. There's been some interesting work published recently from the LGBTQ community and their caregiving experiences and their unique needs. So there are some obstacles, but it's certainly, I would say, a great thing to offer, right? Like, how are you doing? Are you taking care of yourself? Would you like to be seen, at the next appointment? Asking goes a long way. You know what I mean? Just putting it out there and asking them, how are you doing, by the way? And those are things we can do now. We don't need to wait for policy and reimbursement changes. We can do those things now. Yeah, thanks. All right. Well, thank you so much. Oh, unmute.
Dr. Ramos, if you want to unmute and ask.
Yes. Yes. Thank you. This is just such hi. This was such a beautiful presentation. Thank you. But I have a question about transitions of care and communication. So I have a colleague who has been looking at the time point within the emergency room, emergency department encounter, where communication regarding the transition of care, discharge instructions, follow-up care will take place. And it's kind of been an informal, it's kind of hard to develop the study design in the emergency department environment. because there's so many providers. But in the hospital environment, has this been looked at, like to, asking the caregiver at one point during the inpatient stay, would they like to discuss the discharge planning and the transition in care? I think it's an area ripe for research. But sometimes the problem with research is that the results don't get disseminated until there's something publication worthy, rather than it's ready to get integrated into practice now. So just your thoughts. Thanks.
Yes, so thank you for that. I think the one place I've seen that, and there is some research about it, is in the intensive care unit. That, and especially with parents of kids with serious illness who might be in an ICU environment, where they've engaged family caregivers in rounds. So that they can give their input about, and also where they've been allowed to be part of the child's caregiving during the hospitalization. And the closest thing I've seen to that is where I worked with a group that tried to integrate PCAs, personal care assistants, for people living with disabilities who, have their own personal PCA that helps them at home, who knows them really well. And when the person got hospitalized, they wanted the PCA to come in and formally provide care, because these are folks with complex everyday needs. And the PCA tends to know that better than hospital staff. And there were all kinds of obstacles to engaging the PCAs in the personal care on the hospital grounds. It was just a lot of risk management obstacles. And so involved, like asking the caregiver when they could be available, I don't know of any research or literature that's reported about that. And I think, it's more like a feasibility question. How do you make it so that caregivers fit into our rounding schedule? And what can we do if that's not possible to make it manageable? How often is it a factor? Really, how often is it a factor? Because we know in Project Red, there are people who, no matter what you do, they're never going to get readmitted. And then there are people, no matter what you do, they're always going to get readmitted. And then there's people who in the middle, where doing something could actually reduce their risk for readmission. And could you just focus on engaging the caregivers of that group of people as a beginning, as a start, so that they can be engaged? And I would say that, care managers now that work on hospital floors, they start thinking about discharge the day the person's admitted. I wonder what they would say about the engagement of family caregivers from their perspective and in their work, because that could be a beginning of trying to liaison the family caregiver into the discharge planning process. So I agree, it's a great idea. It could be a quality improvement project. So you don't need to have a big research project. I think you could do a little trial and error and see how that goes. And if you do, let me know.
Oh, thank you so very much for your insight.
Great. All right. Well, thank you so much. I'm happy to stick around if anybody has other questions. Otherwise, enjoy the rest of your day. Good to meet you.